before we delve into today's topic, I think it's important to preface this all with a trigger warning. We're going to be talking about BMI. We're going to be talking about weight. We're going to be talking about the impact of weight on fertility, IUI, IVF outcomes. Now, we appreciate that this is a sensitive topic and it can be a triggering topic for individuals. And so if this is something that will be very upsetting or triggering, we advise you not to listen to this episode. In an ideal world, everybody entering into fertility, entering into pregnancy would be doing it with a clean slate, meaning, with a normal BMI, never smoking, not drinking, eating a healthy diet, exercising, fruits, veggies, whole grains, fish, and taking a prenatal vitamin. But that's not realistic. That's not real life. And that's okay.
Yeah, our patients are humans. They're not robots.
Exactly.
Hi, superhumans. I'm Dr. Mavis Garcia.
And I'm Dr. Wise.
We're two of the physician leaders at Markham Fertility Center, otherwise known as Our Baby, MFC.
As fertility specialists, we've witnessed firsthand the challenges, triumphs, and the myriad of emotions that come with trying to conceive. Whether you're just starting to think about having a baby, actively trying, or facing challenges along the way, My Fertility Podcast will be your go-to resource for honest conversations and a supportive community.
So grab a cup of coffee or tea and settle in, and let's demystify the world of fertility together. Welcome to another episode of My Fertility Podcast. Today, we are going to talk about body mass index, BMI, and the impact on fertility treatments. We're going to discuss high BMIs and low BMIs and how it would impact treatments like IUI, IVF, and natural conception. We're also going to discuss the impact of BMI on fertility outcomes for both people with ovaries and people born males at birth.
BMI, or body mass index, is a measure of body fat based on somebody's height and weight through a particular math equation. And so this is a very key health indicator that's widely used in medical literature, whether it's talking about heart disease, lung disease, kidney disease, etc., and fertility, where we categorize individuals in various weight classes. So broadly, these categories are individuals who are underweight, normal weight, overweight, and obese.
Now, we know that BMI is an imperfect measure of health. It is especially inaccurate in people who are athletic or muscular, the elderly or pregnant people, and even certain ethnic groups, because the ratio of fat to muscle can vary greatly amongst people, and that's probably a better indicator of health than BMI itself. But unfortunately, measuring the ratio of fat to muscle is a little bit more difficult to do than just jumping on a scale. So BMI is the measurement that has been used in the medical literature to determine health outcomes.
And if you're interested in calculating your own BMI, there's lots of BMI calculators you can check out online to give an idea in terms of where you're sitting. The reason why we really want to talk about this topic is because we know that the prevalence of obesity worldwide is increasing amongst reproductive age women and in other segments of the population, especially in developed countries. And in fact, the prevalence ranges from anywhere from 14 to 20% and is even up to 60% in some countries. As a result, there's more and more literature about the effects of obesity on fertility treatments, and natural conception. Now, the effect of obesity specifically when it comes to artificial reproductive technologies like IVF, it's still unclear, and there are several contradictory studies, which we're going to go through and hopefully try and make it a little bit more clear.
To be honest, counseling patients around the impact of BMI on fertility, it's very challenging. It is difficult for a number of reasons. Number one, as we mentioned, we know that BMI is an imperfect measure of health. Another reason is, just like Dr. Wise mentioned, the studies are very contradictory. And also, BMI is not something that you can change overnight. If somebody's in a high BMI category, it would take time for the weight to come down. And as you know, time is essential when it comes to fertility. So the concept of I'm going to try to get pregnant when I'm healthy or when I have a lower BMI, or I'm going to delay my fertility treatment for when I have a lower BMI, Sometimes it's realistic for some patients, but it might not be realistic to other patients depending on how old they are and what is their difficulties that they've had in the past with weight. So it's not a straightforward thing where we can just say, hey, lower your BMI and your outcomes are going to be much better. It really is a very specific and personalized discussion around not just the BMI, that's just one aspect of the entire fertility picture, but it's around looking at all the other factors together to make that best decision together with the doctor and the patient.
Another thing is we also acknowledge that losing weight is really, really hard. And that it's not just a matter of saying, okay, lose X number of pounds to get your BMI to a certain point. Not just that it can take a lot of time, but it can be almost nearly impossible for individuals to do. And that can be incredibly discouraging and can delay fertility. And people can be left with no pregnancy at the end of the day because of time. And we recognize that as well, that probably where everybody's body is naturally at, whatever weight they're at, is going to be different and vary from person to person. And I think we delved a little bit into this when we talked about lifestyle factors for women in episode 6. One key takeaway message before we kind of get into this is that I would rather have a patient who has good lifestyle habits, meaning that they're eating a healthy diet 80% of the time. We talked about the 80-20 rule, who is physically active, moving their body, even if that means that they're at a higher BMI than somebody who is at that quote unquote normal BMI, but has other detrimental lifestyle habits that could be seriously affecting their fertility, their eggs, risk of miscarriage, etc.
And I know a lot of people criticize the concept of the BMI and criticize fertility doctors or doctors in general who talk about BMI in the context of health. And I think, to be honest, the criticism is warranted sometimes because I have seen a lot of times where fertility patients with high BMI have come to me, where other doctors have said, you cannot do IUI, you cannot do IVF, you need to lose weight and things like that. And then when you dig deeper, there might be other issues for their infertility and the BMI had nothing to do with it. So I think it's fair to recognize that there is a weight bias in medicine. I don't think anyone is immune to it. I recognize it, we recognize it, and we tried really hard not to let that color our discussions with patients. But I think we do need to recognize that it exists. And the patients that are overweight do experience significant bias in healthcare.
Mm-hmm.
For example, when I see a new patient and we talk about weight, I always ask, okay, so what is your height and your weight? And we get a number. And then I ask them, is this a normal weight for you? Is it high? Is it low? Have you gained? Have you lost? So that I get a sense of where they are at baseline. And patients tell me, listen, I have been like this my whole life. I move a lot. I eat healthy. This is just my body. This is the way that my body likes to go through life. And then I take that into consideration. Sometimes patients say, no, I know that I'm 30 pounds overweight. I know I've been eating terribly and I'm not moving. I don't feel normal. This is not me. And I know that I need to lose weight. And then I also take that into consideration. So I think patients are actually well aware, regardless of the number of the scale, whether that number is healthy for them or not. And I always start the conversation sort of that way, kind of getting an understanding of where they're at.
Let's start by talking about natural fertility. So what we mean here is spontaneous pregnancies. We know that obesity in patients who are obese, specifically people with ovaries, it is associated with an increased risk of menstrual irregularities and anovulatory infertility. And we briefly talked about this in episode 16, part 1 of our series on PCOS. Now, if you exclude those women from studies, even women with regular ovulatory cycles who are obese still experience a lower probability of spontaneous pregnancies. And this was coming from a study in 2007 done by Gesink-Law et al. They found that compared to normal weight women with a BMI of 25 to 29.9, so again, who are overweight, their chances of conceiving were about 0.92 of that of women whose BMI was within the normal range. If a woman had a BMI of 30 and over, her chance of conceiving each cycle was about 0.82 times that of a woman in a normal weight range.
There was another study published by Jensen in 1999 that looked at couples trying to conceive their first child and found that the chances of conceiving was 30% lower for women that had a BMI over 25 versus women that had a BMI under 25. And another study looking at women who were ovulating, working with a fertility clinic, found that they had a 4% lower pregnancy rate per point above BMI of 29.
So, as we talked about in episode 2, ovulation and the menstrual cycle are controlled by a complex hormonal dynamic. Although not completely understood, obesity has been demonstrated to somehow throw off this delicate regulatory process through direct and indirect mechanisms, including insulin and insulin-like growth factors, leptin, which is a hormone that body fat produces, and adipokines. Adipose tissue, or fat, is actually a really important site of hormone production and metabolism. And most sex hormones, estrogen and testosterone, appear to be preferentially concentrated within the adipose tissue rather than in the blood. Therefore, women who are obese have been shown to have a larger pool of these steroid hormones than women who are at a normal weight. And this causes an altered delivery of androgens, hormones like testosterone, and estrogens to their target organs. The concentration of sex hormone binding globulin, which again is another really important chemical that binds hormones like androgens and estrogens, is also increased by estrogens and also decreased by insulin and androgens. So this is all to say that the net effect in obese women is a decreased level of this sex hormone binding globulin, which leads to elevated circulating levels of these free sex steroid hormones like testosterone, dihydrotestosterone, androstenedione, and therefore obesity can lead to a relative state of hyperandrogenism. This then can go on to disrupt ovarian follicular development and contribute to menstrual irregularity.
So far, we have been talking about high BMI, but low BMIs also have a negative impact on fertility. Women that are underweight, which is a BMI below 18.5, can also have abnormalities in the menstrual cycle and ovulation. And this is related to the low body fat percentage that leads to hormonal imbalance, including estrogen, which is essential for menstrual cycle, as we discussed in episode 2. Underweight women may experience amenorrhea, which of course would hinder fertility. Amenorrhea means inability to have a menstrual cycle. The primary mechanism through which low BMI affects fertility is related to hormonal imbalance. Adequate body fat is essential for the production of estrogen, which is a hormone that regulates the menstrual cycle. When there is low body fat, there is insufficient levels of estrogen, and this can lead to long periods of amenorrhea or complete cessation of menstruation. Also, a low BMI can signal to the body a state of energy conservation. Therefore, the body prioritizes other vital functions other than reproduction, and this can reduce fertility and even affect the endometrial lining as well.
So, when we're thinking about fertility treatments, we often will talk about IUI. We had a whole episode on IUI. That was episode 17 of our podcast. When we're thinking about patients who are underweight and who are undergoing IUI, there's really limited studies around this topic. Women who are generally classified as underweight have generally challenges in achieving successful IUI outcomes because, again, of these hormonal imbalances and these irregular menstrual cycles. There was a study published in Fertility and Sterility, which is our favorite journal, which demonstrated that underweight women undergoing IUI had lower pregnancy rates compared to those with a normal BMI, primarily due to this increased rate of anovulation or the absence of ovulation.
Just like low BMI can have a negative impact on the IUI pregnancy rates, high BMI, especially BMI over 30, can also have an impact on the IUI pregnancy rates. There was a study published in Reproductive Biology and Endocrinology that found that obesity, which again is a BMI over 30, it's correlated with a reduced likelihood of clinical pregnancy and live birth following IUI. The exact mechanism remains under investigation, but it might have to do with hormonal imbalances and inflammation associated with the high BMI, as we discussed prior on this episode.
In the United States, 1/3 of adults at their peak reproductive years are obese. And we know that 1 out of 6 couples, or about 15%, will seek out infertility services some point during their reproductive years. So both of these things are common, and both are multifactorial issues with many confounding variables. Therefore, the role of obesity when it comes to ART and specifically IVF outcomes has really not been fully worked out. If you're interested in hearing more about IVF, you can check out episode 14 of our podcast. Koenig et al. Published a systematic review in 2014 evaluating outcomes of IVF cycles in obese patients. A systematic review is a study where they combine a bunch of other studies and pool the numbers so that the study has more people in it and is more useful and reproducible. They pooled 27 mostly retrospective studies. These are studies where they're looking back in time, and they pooled the data. So when they compared overweight and obese patients to normal weight patients, they found the chances of these overweight obese patients achieving a clinical pregnancy was about 6% lower than normal weight individuals. The chances of these patients achieving a live birth was maybe about 10% lower than normal weight patients. So these values were relatively small and they were not statistically significant. The authors concluded that higher female BMI may reduce IVF success rates, but to a small degree, and that there may be many confounding variables that need to be teased out with prospective studies.
Just like we mentioned before, the studies on the impact of BMI and IVF really are confusing and they're giving conflicting information. For example, you just heard the study that Dr. Weiss mentioned, citing only a 6 and a 10% reduction in clinical pregnancy rate and live birth rate. There's another systematic review that looked at women with a BMI of 25 or higher, and they found that the chances of a pregnancy following IVF with a BMI of 25 or higher was actually 30% lower than patients that had normal BMI. They also found a higher miscarriage rate in this population, being about 30% higher miscarriage rate than women that had a normal BMI.
So when we're talking about studies in the world of fertility in general, arguably live birth rate is the most important marker of success. But, this is a very difficult piece of information sometimes to include in a study. And so many studies have identified different specific outcomes that they're interested in. There was another study that looked at BMI and dose of gonadotropins needed to achieve adequate ovarian follicular stimulation in an IVF cycle. This study was retrospective, meaning looking back in time, with 752 women, and they did 951 either IVF or IVF with ICSI cycles. And they found no significant difference between these BMI groups, normal weight versus overweight versus obese, for total FSH dose. They also did some statistical analyses, and they found that being overweight or obese did not significantly correlate to FSH dose. After they did a statistical process where they adjusted for female age at cycle start, the likelihood of a positive pregnancy test, ongoing pregnancy, live birth, was not statistically different between individuals who were normal weight, overweight, or obese. And there are actually several other studies that have found similar results in regards to FSH dose. There was another study by Luke et al. Where they looked at 152,000 cycles with data from the Society for Assisted Reproductive Technology Clinical Outcome Reporting System. This is a big database in the US where fertility clinics in the US will upload their outcome information and information about their patients, and it's all pooled and anonymous for these types of studies. So in this study, they found that cycle cancellation rates, meaning the chances of patients starting an IVF cycle and then being canceled for some reason, actually paralleled increasing BMI. They also found that rates of treatment failure and pregnancy failure began to increase when patients were overweight and continued to rise as BMI rose.
By far, the largest cohort study looking at BMI and IVF outcome was actually recently published. The authors looked at 239,000 fresh IVF cycles in the United States, and they found that live birth decreased with increase in BMI from 31% in the normal BMI to 21% in patients with a BMI 50 or above. This was very statistically significant. And they also found that there was a progressive decline in pregnancy rate and implantation with increasing BMI. So again, a BMI of 30 is different from BMI of 40, which is different from BMI of 50 and higher. Because of the size of the study, the authors were able to do subgroup analysis of patients with polycystic ovarian syndrome. They found that in patients with purely polycystic ovarian syndrome, there was a trend towards decreasing pregnancy rate and live birth rate with increasing BMI, but it was not statistically significant. So what this suggested is that it's not the polycystic ovarian syndrome itself, but the actual elevated BMI that is associated with poorer pregnancy outcomes.
Although there have been studies trying to look at the effects of increasing BMI and outcomes of IVF cycles, the cause and effect is still really unclear. So, probably over time, we're going to see more studies looking at the effects of obesity on egg quality, looking at dose of medication, looking at technical difficulties of the actual retrieval itself, looking at embryo quality and embryo development, and endometrial receptivity. We talked a lot about the endometrium in episode 11 when we spoke with Dr. Chan. Potentially in the future, we're going to see studies looking at obesity and its effect on implantation and that endometrial receptivity. Certainly, further large-scale nationwide studies are really needed to identify these confounding variables that can impact obesity and IVF outcomes.
So if you've listened so far and you find yourself confused, you're not alone. I hear you. It is actually confusing. At this time in July of 2024 that we're recording this episode, there is no consensus regarding the effect of increasing BMI in successful fertility treatment cycles. Some studies have said that obesity has no impact on IVF success, and other studies have shown that BMI actually has a negative impact on IVF pregnancy rates. Really, it does not appear to be a consensus regarding the effect of increasing BMI and successful ART cycles. As you just heard, some studies have shown that obesity has no impact whatsoever on IVF success, while other studies have shown that high BMI have a negative impact on IVF pregnancy rate and increased miscarriage rates.
So, if it isn't challenging enough to figure out about the effect of BMI in women, let's talk about the effect of BMI on the men, on the people who are providing sperm for these cycles. As much as there's limited literature on the BMI of the egg provider, there's even less, unfortunately, when it comes to sperm providers. Now, we did a whole episode on lifestyle factors for men. That was episode 7 of our podcast. Research seems to indicate that men with a normal BMI have better semen parameters, including sperm count, motility, and morphology compared to those who are underweight or overweight or obese.
Men with low BMI, which is a BMI under 18, do face fertility challenges due to hormonal imbalances and reduced sperm quality. Just like for women, low body fat can lead to insufficient levels of essential hormones such as testosterone, which is critical for sperm production and overall reproductive health. There was a study published in 2008 that found that underweight men had lower sperm concentrations and total sperm counts compared to men with a normal BMI.
As with women, we know that adequate body fat is necessary for the production of testosterone and other reproductive hormones, and low BMI can result in reduced testosterone levels, which we know are vital for spermatogenesis and maintaining libido. Another consideration is that men who are underweight may suffer from nutritional deficiencies that can adversely affect sperm quality. When we talked about lifestyle factors, we talked about vitamins and supplements, and so if somebody is not getting enough nutrition, they may not be getting enough zinc, selenium, folate, which we know play crucial roles in the creation of sperm and sperm function.
So we've talked about low BMI in people who produce sperm and the impact of fertility. Now let's talk about high BMI in sperm producers and the impact of fertility. Research indicates that people who produce sperm with a BMI over 30 have significantly lower fertility rates compared with sperm producers with a BMI less than 30. There was a study published in 2013 that found that obese men were more likely to have lower sperm counts and poorer sperm motility, both of which could reduce the chances of natural conception, of course. Some of the mechanism of this could be related to the excess adipose tissue, which leads to higher levels of estrogen and lower levels of testosterone. This hormonal imbalance can disrupt the hypothalamic pituitary gonadal axis, which is the mechanism by which the brain communicates with the testes to create the process of spermatogenesis and sperm production. Another mechanism could be oxidative stress. So obesity is a state of increased inflammation, and the increased oxidative stress can cause more DNA damage to the sperm, reducing motility of the sperm and viability of the sperm. We know that reactive oxygen species are elevated in obese men, leading to compromised sperm function, as published in a study in 2009. And furthermore, erectile dysfunction can lead to decreased natural conception. Erectile dysfunction can happen in obese men due to endothelial dysfunction, reduced blood flow, and psychological stress.
In this episode, we have really focused on fertility, whether it's conceiving naturally, conceiving by IUI, and conceiving by IVF. One thing we have not really talked about is the effects of BMI and pregnancy. And certainly that is a whole topic in and of itself in terms of the BMI that somebody is as they're going into pregnancy and going through pregnancy. And we know that that can carry its own risks as well. We do know that pregnant people with obesity do have increased risks in pregnancy and postpartum, including but not limited to higher rates of miscarriage, higher rates of congenital abnormalities, or rather that the congenital abnormalities are not recognized on early ultrasound. We know that they can have a higher risk of blood pressure issues in pregnancy, gestational diabetes, having large babies, and babies that can experience shoulder-dissociated delivery, meaning that the shoulders are wider than the head. And then there's a higher risk of C-section in women who are obese, who are pregnant. Postpartum, we know that people who are obese have higher rates of infection and higher rates of blood clots, specifically VTE or venous thromboembolism, which can start in the leg and travel to the lung. Pregnant individuals who are obese also have higher rates of postpartum depression. And so it's important to also take these things into account when planning pregnancy. In an ideal world, everybody entering into fertility, entering into pregnancy would be doing it with a clean slate, meaning, with a normal BMI, never smoking, not drinking, eating a healthy diet, exercising, fruits, veggies, whole grains, fish, and taking a prenatal vitamin. But that's not realistic. That's not real life. And that's okay.
Yeah, our patients are humans. They're not robots.
Exactly. And thank God for that. I don't think I could deal with talking with robots all day long. My point is that this is not easy. This stuff is hard. All the lifestyle stuff is really hard. And this episode is not meant to make people feel bad or feel guilty about their current situation, but it is important to provide the information so that people understand and that people are going into things with eyes wide open.
I think another thing that is difficult about BMI is that not only there is stigma in medicine, but also patients feel a lot of shame about it. Like if you tell a patient your thyroid level is high and we need to bring it down, they would be like, okay, yeah, that's fine. It's not my fault. You found it, you fix it, give me the treatment. But when you talk to patients about weight, there is that sense of shame. There is that sense of like, I should be better. I should be eating healthier. How did I get to this point? This is my fault. And I think that's why it's also hard to have those conversations, because there is so much shame associated with the number of the scale. And unfortunately, that has a lot to do with societal expectations and Instagram and all skinny influencers out there. So we recognize that. We recognize that there is a layer there of socialization, for lack of a better word, when it comes to having those discussions, which is why we are sensitive to this conversation. And whether your BMI is high or low or normal, we want you to know that your BMI doesn't define your worth or who you are or your ability to become a parent or how much you want this. You are loved, you are worth it, and you've got this.
And that's a wrap for today, Superhumans.
If you're looking to connect, get social with us. Follow us on YouTube and Instagram at My Fertility Podcast or visit us online at markandfertility.com. And don't forget, follow, subscribe, and share your favorite episode.
Thanks for listening to My Fertility Podcast and for being a vital part of our community. We know you've got this.
We're signing off until next Tuesday.
If you found this episode of My Fertility Podcast helpful, please take a moment to head over to the review section and leave us your thoughts. Your reviews and comments are incredibly valuable to us and help guide future episodes. We also welcome you to direct your questions to info@myfertilitypodcast.com.
My Fertility Podcast is produced by Rabbit Media Inc. in conjunction with Dr. Garcia and Dr. Weiss. Music from Mix Kit Raising Me Higher by Audrey Stellino. My Fertility Podcast is not intended to replace any type or variation thereof professional medical, health, or legal advice, nor should the content be taken as medical advice. Please contact your primary healthcare professional regarding any medical questions you may have. The information presented in this podcast is based on the knowledge and understanding of the host at the time of recording. Medical knowledge is constantly evolving, and new research may change the understanding of health-related topics. While we strive to provide accurate and up-to-date information, we do not guarantee the completeness, accuracy, or timeliness of the content. The views expressed in this podcast by guests are not those of the host or the management. This podcast is not intended to impose any type of discrimination. My Fertility Podcast and its management are not responsible for any losses, damages, or liabilities that may arise from the use of this podcast.